Okay, we're going to get started. So as I've said, good morning and afternoon. I'm Dr. Patrice Lindsay, the lead for our stroke and engagement strategies at Heart and Stroke. Really huge warm welcome to everybody on this November day. We're very pleased to be able to offer you this webinar. It is such an important topic, and astounded to tell you that for this webinar, we had over 1,300 people register, which just emphasizes the importance of this topic. And so thank you to everybody who's joining us today. And we hope that you learned something, that you can take something away either in your own lives or in your practice. So we will get started. I'm very thrilled to be here today with my colleague, Stephanie Tesseyman. Stephanie will introduce herself in a sec. So at Heart and Stroke, we've recently launched our Women's Campaign 2.0. We've been working on our women. And so this is really an opportune time for us to bring out the issues that are less talked about for women and mental health. So I've been working at Heart and Stroke for over 10 years and in the stroke strategy area for over 20 years. I'm a nurse by training and really excited to be part of today's session. Stephanie, would you like to introduce yourself?
Sounds good. Thank you. I am Stephanie Tesseyman. I'm the specialist of lived experience engagement. I'm in support at Heart and Stroke. I have a background in working in the mental health field, as well as in system navigation and in community health. I'm looking forward to introducing and hearing from our presenters today. So just to start off, today we would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land which we each call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call these lands home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We're gathered today because of a shared commitment to equity, including health equity and reconciliation. I encourage you to reflect on what that means for you and your work and in your lives.
Thank you, Stephanie. So today's topic, as we've said, is women and stroke and mental health. We haven't done a lot of talking about mental health. One thing we learned during COVID is the need, the increased need for this to become a normalized part of our lives and to be more accepting of people who are addressing mental health issues, whether they are just smaller issues of stresses and anxieties right up to really significant issues. So when we talk about mental health, it isn't just about big, really all-encompassing issues. It could be anything on that continuum. So we really want to acknowledge that and address these issues for everybody. So today we're hoping that we'll be able to recognize the importance of these conditions, the role they play in people after stroke, maybe talk about some of the signs and symptoms, and really importantly is discuss strategies. How can we all help both acknowledge it, recognize it, ask for help as a person experiencing it, and as healthcare providers to provide that help when needed and in a more timely and open way. So this is really important. One thing I do want to mention is when we released our report in June. So in June of this month, as I mentioned, we released a report on women and mental health and stroke. Got a lot of feedback that, well, why just women? So we have focused this particular report on women because that is one of our priorities right now. But for all the men listening and for the men in your lives, this is an issue for everybody. Whether you're a young person with stroke or an old person with stroke, male or female, man or women, and from all different cultures. Mental health affects everybody after stroke. We happen to be focusing on women today, but I want to make it clear that these issues and the strategies and some of the things you learned today do apply to everybody. What we're going to tease out a little bit more is some of those specific issues that women experience. But please be sure that everybody understands that this is for everybody. On our stroke report, these are just some highlights of some of the things we brought out that, people have to learn to be comfortable to speak up, that, at those early stages after stroke, it is hard. It's hard to even know there's so much going on. And I personally had a stroke at the age of 38, so I understand that as a woman. It's hard to tease out what is the stroke, what is the health part of it, the physical part of it, and to really understand and sort out where there might be mental health issues. Sometimes that takes a while to let all the dust settle to really understand that. Sometimes it's obvious right from the beginning. We know that from the research that women are hit harder by depression and anxiety after a stroke. It happens more often than with men. So one of our guests today, actually two of our guests today were quoted in the report. So Abe, I took one of your quotes. I think Abe said it really well when he said, it's the same circuitry, whether it's, the stroke itself or the mental health issues that come with it. It's all happening within the brain, same circuitry. I love the way you said that. And that we really can't separate these out. Recovery really has to be, and care for people with stroke has to be comprehensive. You have to look at the whole person and understand both the physical changes, the cognitive changes, which are often seen, as well as the psychosocial and mental health changes. So we really want to think about that in a much more holistic way than we have in the past. Next. So I will now turn it back to Stephanie.
We are very grateful and honored to have these three guests with us today. They are experts on the topic of mental health, and we look forward to hearing from their personal and professional expertise. So first, I will introduce Becky Morrison.
Hi, everyone. My name is Becky. I am a mental health nurse practitioner in Calgary, Alberta. Ran the Rapid Access Addictions and Mental Health Program. And at the age of 36, I had a right parietal stroke. I was recovering in Hawaii post failed fertility treatments. So I was on high dose estrogen. I had just had surgery for an ectopic pregnancy. And I was sitting at the beach watching the whales breach when I had this egg timer. Ding. And it just felt exactly like that. And I sat up and was like, something's wrong with me. And I didn't know it was what. And all of a sudden, it felt as if I was underwater, like I had water in my ears, and I could say some words. What are you saying to me? Which didn't really make sense. So I did what I tell my patients not to do, is go to the bathroom. I couldn't understand numbers at that time. I was really panicked, but I didn't know why. The second thing that I did, which I tell my patients not to do, is I drove to my hotel because my husband had been drinking. Did my own assessment in the shower alone because I felt I really don't know why, to be honest. I don't know why. And I could kind of talk and I couldn't talk, and I couldn't understand, but I couldn't. So none of that really made sense to me. I didn't have any risk for stroke factors at the time that I was aware of. And then the third thing I did that we never tell our patients to do is to get on a plane. And I flew to Calgary and had another stroke in the air. So after about 2 days, I ended up at the foothills, diagnosed with right parietal stroke. I found out that I was ambidextrous. So I was, 1 second, please, Lincoln, just give me 1 second. This is why I could still kind of read, write, or talk, because I was ambidextrous. First person that I reached out for and requested was a psychiatrist, because at that time I could not access my coping skills. I was a writer. I worked out. I love socializing with my friends. I couldn't access my coping skills, and I was in the darkest place in my life, where I said to myself, if I didn't get better, I was going to end my life. And so here I am without any coping skills and in the worst place in my life. So I reached out to a psychiatrist and advocated aggressively for my mental health. And that's my story.
Thank you so much, Becky, just for sharing those details from the beginning of when you first experienced your stroke, as well as just comparing it to your own professional life of what not to do. But we do appreciate you sharing with honesty just your experience with stroke and with mental health. Next, we have Katherine Isaac.
Hi, everybody. I'm Kathy. I'm married. I'm a mom of 2 teenagers. I live in Ontario, and I'm a career techie. Spent my entire career in technology, and today I work as an executive at a cybersecurity firm. I had a left cerebellar stroke in 2021 while I was battling COVID-19 pneumonia in the ICU. I stayed off the ventilator, so I was awake for my entire ordeal. But because of the circumstances surrounding the situation, no one noticed that I had a stroke. I was isolated. I was very, very sick. So any of the symptoms I was having, I think everybody just related it back to the medicines that were being pushed into me and what I was going through then. And I wasn't out of bed. I was in bed for about 2 weeks straight, so no one noticed until some physiotherapist came to assess my readiness to go home. And this was about a week, or at least we think it was about a week after I experienced a stroke. So that in itself was a bit of a shock, surviving that whole experience. And then being told, as I'm getting ready to go home, being told, sorry, you can't go home, you've had a stroke. So there was all of that to deal with. I've spent the last 2.5 years working really, really hard at my recovery. I've been doing very, very well. I have ataxia on the left side of my body, so I'm still, dealing with that. And then there's the invisible stuff that, I just try to accommodate as much as possible. That's
Thank
my
you so
story.
much. Yeah, thank you, Kathy, just for sharing again, just your experience with COVID and then following having the stroke and just sharing your recovery. Lastly, we have Dr. Abe Snaiderman.
Well, I have not had a stroke yet, and I'm impressed by the strength of these two ladies. And if I ever happen to have one, they are inspiring. Nothing I can tell you would be as powerful as what they can tell you. So I don't have a lot of time, so let me go back to the 17th century, where René Descartes, among the many achievements he did as a philosopher, mathematician, and being one of the first rationalists, decided that brain and mind are very different. So of all the strategies and all the philosophical achievements he developed, these ones he screwed up. Because we now know that brain is mind and mind is brain. And we know now that brain is one of the main organs that use energy in the body. So not surprising when somebody suffers a brain injury, whether it's a stroke or not, they feel extremely fatigued and other functions that normally wouldn't be associated with a right side stroke or a left side stroke get affected. Depression is a brain disease. We have to be very aware of that. We know from studies that depression happens more often in women in general. Preparing for this talk this morning, I was reviewing some numbers, and there are about 16 million strokes annually all over the world, but about almost 250 million cases of depression. 260 million people have been diagnosed with depression. So it's not surprising that they too mesh. It is much less conspicuous to diagnose depression than to diagnose a hemiplegia or ataxia or aphasia, problems speaking. We have to look for them. We have to search for them. I'm very happy to see that Rebecca was able to advocate for herself. Being in the field, she was quite sensitized as to what to do, but the vast majority do not know this. So if a woman after a stroke is not perky enough or not able to react to the therapies or participate in the therapies or able to go home earlier, or is irritable or impatient or tearful, not sleeping well, not eating well, not motivated, all of those are signs that there might be an impending depression. If we look forward, in the first year after a stroke, my mistake, about a quarter of patients will get depressed. And that used to be the number. But when we follow patients forward, by the end of the first year, up to 2/3 endorse some symptoms of depression. Now, why is it that women are more depressed? We're still quite not certain, but there are some clues that are easy to tease out. The first thing is, well, women have 2 X chromosomes and they have hormones, we guys don't. So that might be a moment, yes, that might be a predisposing factor, but it's way more complicated than that. For starters, women, and I'm generalizing, tend to speak up more about their own feelings and tend to acknowledge that things are not right. We guys tend to go, no, we're tough and strong and we're not gonna admit. So we get grumpy and moody and irritable, while a woman might get more weepy and more expressive of hopelessness and sadness. And so women are more prone to be diagnosed with depression earlier and more frequently because the symptoms are there. We guys tend to be a bit more dense when it comes to seeking help based on social roles. If a woman has a history of anxiety or depression pre-stroke, then they would be more prone. And we know that women suffer more from anxiety and depression, even in the absence of any medical illness. A very interesting factor is the issue of inflammation. We know that stroke means death of brain tissue. And when tissues die, there's usually an inflammatory reaction around that area. But we also know that in depression, there's a heightened inflammatory response. So we're starting to understand that this is an inflammatory process, both stroke and depression. There are issues in menopause, for example, that some research suggests that menopause is also associated with higher levels of inflammatory markers. So we start getting a confluency of all that.
Thank you so much for all these insights. All in your introduction, we really appreciate it. Just jumping right in. I just wanted to cut into that first question so that we can have some other ideas on we'll start with just why is the topic of women and mental health following a stroke so important, and especially since it's not been publicly discussed much before. So thank you so much, Dr. Abe Snaiderman, for starting us off. And I'll just jump over to Rebecca just to start the conversation. So just from your perspective, why is the topic mental health so important?
Well, I feel like it's common sense. You've had the most traumatic experience of your life. How would it not affect your mental health? And women are really good at putting themselves at the bottom of their to-do list. When they're a parent, when they're a wife, when they're taking care of their parents, we always take care of everyone else first instead of ourselves, and then we break. And that's why it's really important, because if we aren't mentally well, then how are you physically well? It's just not possible. So I was very grateful to have a psychiatrist through my whole recovery. And without that support, I don't know that I would be as far off as I would. The feelings that you experience, the stigma, the shame, the self-loathing is pretty overwhelming when you're learning new coping skills. If you couldn't access your own, all at the same time is completely overwhelming.
That's a really good point. Thank you so much. And Kathy, I just wanted to get your opinion as well, your perspective.
Yeah, I mean, it's interesting that Rebecca says it's like, sorry, Becky, that it's, that why wouldn't you have the situation? You know, it never crossed my mind. Then again, it never crossed my mind that I would have a stroke, right? Like I was fit, I was healthy, I had no markers. It never crossed my mind that I would have this mental health impact. And accepting the knowledge that I had a stroke, it was like, all right, got it. This has happened. I will accept it. What do I do next? I got my therapist. I got my occupational therapist. Cognitively, I even studied and wrote a cybersecurity exam just to prove to myself that I still got it. Like I just went bang, bang, bang. How do I move forward? And I had absolutely no idea that I could have some kind of mental health impact. It wasn't on my radar at all. And I didn't figure it out until I was in the middle of some really compromising situations, right? One of the things I didn't know was that my tolerance level for certain things had changed, and nobody told me until I was in the middle of a grocery store or, you know, in the middle of a hardware store or driving my car, that I just couldn't tolerate things the way I did before. And completely losing it publicly more than once is when I took a step back and was like, who is this person and why is this happening? And could this possibly be related to stroke? And so that's why I think it's important to talk about it, because I think we talk about all the other stuff. And people like me who actually aren't paying attention to all of this, it was right over my head and I had no idea, right?
So Dr. Snaiderman, picking up on what Katherine's just said, you were starting to tell us about the differences between men and women in stroke. When you think about depression, in women. Do you see differences in terms of timing? Like, it's interesting because Becky and Katherine both had different time frames before, Becky, because of her experience, picked up on it right away. Where for Katherine, and even personally for myself, didn't even cross my mind. I was out to prove to the world that I was fine, right? So are there differences in, what are some of those other differences in men and women when it comes to mental health post-stroke? Is there a time difference? Is there symptom difference? Or is that something we can tease out?
It is hard to tease out, but there are several markers. So if we use a biopsychological and social model, biologically, there are hormonal stages in a woman's life. So pre-menarche, before a woman goes into menstruation cycles, it's very unusual to see depressions. It's very common to see anxiety, but unusual to see depressions. After female starts having menstruation, we start to see a gradual escalation in anxiety and depression given the wrong genetic and social psychological milieu. We don't see that in males. There are also different stages in the life of a woman, postpartum, for example. If there have been psychological and social challenges, and there's again the genetic predisposition and a history of anxiety or tendency towards sadness, then postpartum depression comes about, and that's another risk factor for stroke in the postpartum period. And afterwards, as I was saying, menopause, when there's a sudden withdrawal, not so sudden, but a withdrawal of hormonal support, so to speak, at a time when all the changes are happening in a woman's life. Becky said it very well, as did Katherine. There's a much more common social tendency for women to put themselves at last and be the caregivers. It happens in our wards all the time. Who's the caregiver? The daughter. There might be 3 sons, and the daughter is the caregiver. Now, from the psychological point of view, as I was saying at the beginning, women tend to be more sophisticated in terms of identifying emotions. And Becky was particularly well trained to detect her own emotions, which speaks highly of her insight and the capacity to self-reflect, and the fact that she did not have anosognosia. So she was able to recognize, I'm not functioning well, while Katherine might have had a touch of anosognosia, not able to recognize how sick she was emotionally. And to be fair, I really don't like the term mental health because it stigmatizes. I think it's brain health, and stigma becomes another issue. Stigma is much higher for males. We need to be the providers, the protectors, the partners, the parents, and any other P adjective you can come up with. Women are more sophisticated in that. Women also have a better support network that might be able to tell them, you're not functioning well, something's going on. It's easy to miss depression in the acute care setting because everything is urgent, everything is an emergency. We need to rescue neurons, time is brain, we need to get on, et cetera, medical treatment. And then they come to rehab and we start picking up the pieces and we start seeing this patient's not sleeping, not eating, not participating. There's a lag in the thought process. They're not thinking as fast, and we cannot explain that because of the areas of the stroke that were affected. In terms of which areas of the brain are affected, both genders have the same areas affected. Depression tends to happen more in females, or we tend to detect it more in females earlier than in males. If depression is not treated, it tends to veer slowly into a state of hopelessness. And a red flag is, I am a burden to my loved ones, my caregivers, they will be better off without me. That's a red flag. And we hear that more from females than from males. Males tend to clam up and quiet down and become, as I said, irritable, impatient, withdrawn. Females are more expressive, so we tend to pick it up. Females tend to attempt suicide more often in general, but males succeed more often because they use more lethal means. And that goes through the roof after a stroke because of the issue of now I cannot control my bladder, or control my bowel, or move, or take care of myself, or work? What about my family? What about the financial pressures? All of that still happens to a female on top of the caregiver roles.
And I'm just going to pick up on something you said and tell everybody in our audience. So thank you for that very important information. I just want to say to everyone who's participating today, this is obviously a very sensitive subject. If anybody is feeling triggers, or if this discussion is starting to bother you, please reach out to us. You can post something on the chat and we will reach out to you personally, or reach out to some support system if you're needing any help, or if this is causing you any stress. We should have said that at the beginning, sorry. But please, we do acknowledge that this may be very difficult. We're seeing some comments in the chat already about people saying, oh, I'm not alone now. Just that this is really reassuring to them in some ways. So I'm going to turn this over to Katherine and Rebecca and ask, as people with lived experience as women, what were the biggest challenges for you? And Becky, I'm going to generalize this a bit more for you because you recognized right away. But what were some of the challenges, either for you personally or for other women that you've dealt with in your professional role, in terms of acknowledging mental health and seeking help?
Well, one, as I'm opening up a sucker for my 4-year-old, is the role of a mom when you're trying to recover post-stroke. That, as we just talked about, being a burden was the most horrific feeling I had ever felt. And the urgent need to be my old me as quickly as possible was front in my mind, which actually worked against me because I rushed treatment and I rushed going back to work and I rushed being normal again. And when I did try and be my old me and go back to all of my roles, I couldn't. And again, thankfully, I had support who appropriately let me fail to recognize that I am a new me, and that's okay. It's also okay to not be okay for a while, and went at a pace that was safer for me and my family. And again, I know that if we don't take care of our mental health, then we can't take care of the people that we love. And I know that. And I had to argue a lot of negative thoughts, the stigma, the shame, the feeling of being a burden, argue that and put my mental health and my physical health first before anything else, and asked against my will, asked against who I am for help for a very long time, and then demanded it when I didn't get it.
I wonder if I can comment something that it just occurred to me. As Becky was talking about, one of the things we seldom ask about and we seldom consider, and yet is crucial, is the issue of intimacy and sexuality after a stroke, and self-image, which again ties in with depression and anxiety and issues of societal roles. And those are items that need to be asked about, that need to be inquired about, and that women need to know that it's part of a normal function to recover sexuality, just that it'll be part of a normal function to hopefully walk again and talk again. And the reason why I'm raising this issue is that that's another marker for depression, lagging of libido.
No, that's amazing. Thank you so much for throwing that in and for your comments, Becky. So Katherine, over to you in terms of challenges. What were some of the challenges from your vantage point that women face in addressing mental health after stroke?
Yeah, Becky hit on it right there. For me, the biggest challenge was asking for help. Once I realized and recognized, what was going on, now what? Like, what do I do next? Again, keeping in mind that this happened to me during the pandemic, and it was the early days of the pandemic, I was around the same people all the time, my immediate family, my parents, my siblings, and their kids. And so, those people know me very, very well. They know what I'm capable of. And for me, I know what I'm capable of. And asking for help felt like an admission. I'm not capable of those things anymore. And that was a big challenge for me in terms of figuring out how to Like, how do I say to them that I love my nieces, but they're just too loud and I can't do that. And the dog's barking is too much. And I just didn't know how to indicate that I needed help and I needed more support. And just like Becky, I got back to work virtually as quickly as I could and was trying to do all these things. And I think that was my biggest thing was if I say I need help, then I'm admitting I'm not okay. And that was the biggest struggle for me. I'm a very independent person. I'm a middle child. I've always been that way. And so this was one of those things where it was like, I don't have those tools in my toolbox. I don't know what to do with this. That was my big challenge.
Thank you so much for sharing that, Kathy. And I really appreciated your comments, Becky, just talking about the feeling the need to rush to get back to yourself of who you identified with pre-stroke, and Kathy just explaining the difficulty in asking for help and to verbalize it, and also to explain your new needs as someone that was recovering from stroke. So thank you just for sharing that experience. So if we look at what can we do about it, if we move into what are some practical strategies that healthcare providers and women experiencing stroke can apply now immediately to positively address mental health issues in women, even with these challenges that you've mentioned. I'll start with you, Dr. Abe Snaiderman. What are some practical strategies?
The most important issue is education. Education not just to the patient, the stroke sufferer, the survivor, but education to the family too, the caregivers and the family, so that they can understand that fatigue is universal after stroke and it's worse between 1 and 3 p.m. Depression is very, very common and it's not their fault and it's not because they had a stroke and who wouldn't be depressed. It's a neurological condition. So number one, recognize that you have two illnesses, a stroke and depression. Number two, recognize what are the symptoms. So the feeling part of depression, negative thoughts, thoughts of guilt, thoughts of shame. Then we go to the physical aspects, all of the automatic pilot functions, sleep, appetite, energy, attention, sex drive. All of those get affected. You might be not sleeping or sleeping too much, no energy, lack of appetite or excessive appetite, and zero sex drive. And then afterwards, we go to the more in-depth negative feelings, suicidal thoughts, thoughts of hopelessness, severe thoughts of shame, guilt, self-image, lack of interest, not being future-oriented. So all of those are the so-called invisible disability. It's easy to diagnose somebody with aphasia or having the inability to speak or being paralyzed on one side. It's very difficult to diagnose somebody who cannot speak and is depressed, and whose only way to express depression might be throwing things or being irritable or being withdrawn. So there has to be a high level of suspiciousness. The third thing is, and this is the toughest one, nationally, we have a huge crisis when it comes, and I don't mean this lightly, when it comes to mental health. There are very few mental health providers in the world, and even fewer neuropsychiatrists that specialize in stroke and brain disorders with psychiatric conditions. So reach to the primary care provider, whether it's a practical nurse, whether it's a social worker, whether it's a psychologist, whether whomever, a physiotherapist. I find I'm spoiled. My teams here are superb at picking up depression and anxiety, and their physios and OTs and speech paths. So express concerns. Say that you are having thoughts that are unwelcome, that you're perhaps crying too much where you didn't want to necessarily cry. That might or might not be depression. And the fourth thing, and perhaps the most important, I keep on saying the most important every time I say a point, but bear with me, please. You have to be flexible when it comes to treatment. I cannot tell you how many times I have people telling me, I want you to cure my depression, but I don't want to take medication. Okay, it's like saying, I want you to take my appendix, but don't use a knife. So you have to be flexible. Not every depression needs medication. The vast majority does not. But in stroke, we're dealing with two neurological conditions. And oftentimes, the inflammatory process that produce the stroke might produce depression, and we don't have a clue how to treat inflammation that might cause depression. These are still experimental. So if you need a medication, for crying out loud, these medications are safer than aspirin that you probably take for your stroke. So be flexible. Recognize that you might be afraid of certain treatments. Talk about it. If you are able to get to a psychiatrist, a psychologist, a psychotherapist, social worker, etc., please do so. Express your feelings. Don't be embarrassed. Don't be ashamed. It's not your fault. Nobody raised their hands and says, I want to have a stroke, just as nobody raises their hands and says, I want to get really depressed because it's fun. So it's not your fault. Number 5, partner is important if there's one. Depression, just like stroke, I've always said this, I've said this for 30 years. I was 10 when I started. Depression affects one brain, but 10 people. So it is one organ, one brain, but 10 people are going to be affected. Kids, particularly, might not understand why mom is all of a sudden not wanting to play, or irritable, or moody, or crying all the time. They might blame themselves. Maybe something I did as a child. So that is important.
Thank you so much for those 5 very clear, practical strategies. I just wanted to also highlight that in the chat, we have put the support line for anybody that is wanting to speak to a mental health professional immediately. It is available 24 hours a day, 7 days a week. And just like Dr. Abe Snaiderman said, it's just about reaching out and saying, I just need to talk to someone about how I'm feeling. And I just wanted to quickly jump back to Rebecca and Kathy. I'll start with you, Kathy, just around what are some practical strategies that that can be used right now to deal with mental health?
Yeah, for me, what I started doing was switching to accommodation, right? Like figure out what do I do, recognizing my triggers and accommodating as much as I could. I know that I have like when it comes to noise, my tolerance level is non-existent. So I invested in earplugs and some noise canceling headphones. When I'm grocery shopping now, I've got headphones in. In my house, I have headphones on once everybody comes home from school, and you know, I say my hellos, I greet everybody, but if I'm cooking and I got to focus on cooking, I probably have headphones on. And so acknowledging things like that, setting my bedtime a lot earlier than it used to be, and actually going to bed and winding down to manage my fatigue. And when it comes to fatigue, even the people I work with understand that Wednesday mornings are sacred. I book nothing Wednesday morning. I don't wake up to an alarm on Wednesday morning. Wednesday morning is it's hump day. That's my, rest and recovery. And it's the time that I get to kind of regain some of those energy credits. So I kind of started to understand what my triggers are, what I need to stay healthy, and bake that into my schedule. And now that I've gotten better at acknowledging my situation and asking for help and being more transparent about what was happening with me, I make sure everybody around me knows it as well. So that if you're booking a Wednesday morning meeting, it better be for a really good reason, because that's my sacred time. And if someone does book in that time and I have to be there, then I accommodate elsewhere, right? Then maybe my Wednesday afternoon today is going to be the day. And so I've kind of switched to that, because at the end of the day, I recognize that it's not like up to everybody else. It's up to me. And especially when I'm out in public, I look normal. Nothing looks different about me. And so I can't always expect that people are going to understand that these are my triggers and right now you're pushing my buttons. They don't get it. And so I've learned to walk away from a lot of things and just say, not today, and just kind of manage myself from that perspective.
Wow, thank you for those clear, concrete examples. And Becky, just if you had a few points to share.
For healthcare providers, I would say first is you got to listen to your patients. A lot of us have atypical symptoms, so don't ignore them. Listen, I thought I had a follow-up stroke, and I was sent by my stroke team to the emergency room for a CT scan of my head, and I was dismissed because my symptoms weren't typical. And if I hadn't advocated for myself to please look at my EMAR, please look at my file, stop dismissing me, he would have sent me home. And after then took me seriously. So one, please listen to your patients. Two is education, again, about mental health. I mean, you could easily break it down into something called the polyvagal theory. When a person is really shut down, if a person is very volatile with their emotions, like you can easily see how people are struggling with their mental health with just asking a few questions and educating yourself about that. And then three would be follow-up. Sometimes we say you should definitely see someone about your mental health, but not help them set it up and follow up if they've followed through on their recommendations of mental health. As a patient, I had to recognize my triggers and for a while ignore them. I did have noise canceling headphones. If I was in a busy environment, I always had to step out because the pressure in my head was too overwhelming. Sleep was important. Sleep when you need to sleep. And that's it. I had to sleep quite a bit. Meditation. And then I had created my own coping skills until I could use my old coping skills. So I like to water. I really like to water. I can pretty much water anything now. And Lego, because those are the things that I could do at that time. Yeah.
Thanks so much, Becky, for those comments and for, just really thinking about practical strategies that we can do. We're now going to turn it over to audience questions. There's been a lot of them, but some, as I'm reading them, there's some themes that are coming out. So I'm going to turn the first question over to Abe, and then Katherine, Rebecca, feel free to jump in if you can, or if you have anything in addition. So Abe, one of the big issues, you've all talked about reaching out and getting help. So COVID has had some really serious impacts on availability of psychotherapists, psychologists, social workers, family doctors. We know that, a quarter of all Canadians almost don't have a family doctor. So when you said go to your family doctor, 6.5 million people in Canada don't have one. So lots of questions about who to turn to and where to get that help. The other thing, and I was just trolling before this webinar over the weekend, I was looking. Some psychotherapists and social workers out there are charging upwards of $200 to $300 for a 50-minute session now, whereas pre-COVID that was half or less. And not everybody has the financial means to pay that if you don't have good insurance or through your work. So how do we address this issue?
Do I start from the political sphere and go down, or do I start from what I really feel?
Succinctly, practically, what do the people watching or listening to us today, how do we, for health professionals, where do they suggest people go? And for people with lived experience, what can we do living in this weird reality right now?
It is terrible. And I don't have a clear answer. If I did, I would be running for office. But we do know, in worst case scenario, every hospital in this country has a crisis team. There are crisis hotlines that can be accessed either by phone or online. These days is both in the same machine, that can be reached for. There are crisis teams that are covered by provincial programs that do short-term psychotherapy. I don't know in your particular province what is available. We have had for many, many decades a neglectful approach to mental health because nobody wanted to talk about it. It's shameful, it's stigmatizing. Nobody wants to raise their voices and say, I'm depressed, or I'm hearing voices, I had a stroke, or I'm feeling really hyper, because it's embarrassing, it's stigmatizing. It behooves us as professionals to raise the voice, as we're trying to do, and we're trying to do for a long time, to the powers that be. So this sounds glib, but please bear with me. Call your MPP or your MP or your member of legislature, let's say, as whatever, your legislature, assembly. How's that for word finding? And please raise the topic. If we don't speak out, nothing changes. I truly believe it, especially now these days in the world we're living in, with so much bad news and so much trauma happening. All of this field is being neglected. Is much more sexier than to talk about cancer and other maladies than to talk about depression. And yet it is the most common illness we're seeing.
Can I
If
just
you
say
do,
something?
go
Sorry.
ahead.
Yeah, so Kathy, go ahead. And then Rebecca, I want to hear from your perspective as well.
Yeah. I've thought about this a lot because I was like, you know, the day after I left the hospital, somebody came to my house and walked around and talked about safety things and said they could help to get bars here, and talked with my husband even about how to take care of me at home and all that stuff. Then I got, you know, a call that this is the day to show up for outpatient therapy and this is where it is. And somebody took care of all of this for me. I didn't make those appointments. Somebody took care of this. And I said to myself after the fact, why didn't anyone ever call me, like a social worker or somebody, to just talk to me and say, how are you doing? Because although my family doctor would ask me how I'm doing, and my speech therapist, my occupational therapist, my physiotherapist would ask me, I always just said, you know, I'm good, I'm working through it. Nobody ever specifically thought to sit and, like, you know, with the one goal of assessing my mental health. And, you know, like I didn't know I had an issue. And I thought to myself, even in the hospital, it would have been great if somebody had come and sat with me for even 30 minutes just to kind of figure out how I'm taking the news and give me some resources and tell me that this is typical, that mental health situations are typical post-stroke, and here's what you should do. Nobody said anything. And so I think with all of the support, I was given lots and lots of great support post-stroke. This was where the gap is, I think, is nobody said anything to me about it, and I didn't even know it was a thing.
Thanks, Catherine, for raising that. And I'm going to plug. So the Canadian Stroke Best Practice Recommendations, for anybody watching, knows that those are the Canadian guidelines. In fact, do say that. So we have a whole section on mental health and depression. And the first recommendation is everybody who's had a stroke should be assessed. And not just, as Abe pointed out, acute care isn't necessarily the place to pick that up, but throughout transitions from hospital to home, through rehab, for outpatient services, and then back into the community with primary care. So this is something, and thank you for raising that, Catherine, because it is something that should be done on a, you know, not necessarily every 3 months. We won't put a timeline on it, but it should be done at, you know, throughout that recovery period. Even as Catherine said, if you look well, you're walking, talking, functioning, you know, to the outer eye, it doesn't necessarily mean you don't have issues or things that you're struggling with. Becky, I want you to jump in on this one. Sorry, Catherine, did you want to make another comment?
No, I'm just saying I would have loved that. I would have really appreciated that, but I didn't get that service.
No, that's amazing. That's such a great thing to have brought up. I'm really glad you did. Becky, do you want to jump in on this one?
Sure. So sadly, post-COVID, there are less of us. There's less mental health supporters instead of more, and we need more. And working in mental health for over 17 years, one of the first things that I always recommended to my patients is what can you afford and what you can't afford. So if you can't, one, access a provider for months, what can we do in the short term? Or if you can't afford it, what can we do that's free? So there are support groups online for people who have gone through a traumatic event, stroke, loss, where they can at least connect with people who are going through what they're going through. There are books, again, these aren't ideal. We want someone to access mental health if they can't afford it or to stigmatize at that time. There are things that they can do that are free and in the comfort of their own home. If you can access a computer, I couldn't. Using a computer really hurt my brain. So there are a lot of free online support groups. There's like for me, there was a aphasia group, support group in Calgary that is mediated by somebody as well. So there are things that can be done. There are books. In hospital, there is mental health teams that you can access, which I did, that people might not know, even if it's a one-off. This therapist gave me a day-to-day routine for a couple of weeks to get to my therapist and new coping skills. And it's because I knew where to access them. So again, in emergency, if you're hospitalized, they are there. And if you can't afford it after, there are some things that can help even for the short period of time.
Canadian Mental Health Association, it just occurred to me, is also a resource.
Awesome, thank you. I have two more questions from the audience, and then we're going to wrap up. So this one I'm going to direct to you, Abe, and then I'm not sure, Katherine and Becky, if you have any other comments. Abe, in your opening, you talked about people with aphasia. So for those of you unclear, aphasia is when you have speech issues, either understanding what people are saying or being able to verbalize and speak because of the way the stroke's affected you. I know from all the experience I've had over the years working with people with stroke, sometimes people just automatically assume people with aphasia are depressed because they can't speak or they start isolating themselves. On the other hand, there's no great tools out there to actually assess for anxiety, depression, and other mental health issues in a person who's aphasic. They think, oh, they can't talk, so I won't bother. Can you comment more on this? You raised it at the beginning, so I wrote it down like I wanted to come back to that. And several people have actually put that in the questions. Can you talk about aphasia and how we approach that with depression?
Because of where the brain's regions that are injured that produce aphasia are, those are the same areas that tend to be associated with depression, frontotemporal areas. So very highly correlated. There is a tool, aphasia depression inventory, I think. If you Google aphasia depression inventory or scale, it pops up right away that can be applied to a person with aphasia. Our speech pathologists here screen everybody for depression. They're really skilled about it. I work in a neurorehabilitation hospital, so I realize that is different than in the community. However, it needs to be assessed at the outset, if for nothing else, to get a baseline. And not every patient that cries is depressed. There's such a thing called pathological laughter and crying syndrome, in which the patient is not depressed but can control emotion. But I'd rather you err on the side of caution and screen everybody with aphasia for features of depression. You might have to address reliable yes and reliable no answers to see whether the patient is actually saying what they need to say and what they want to say. But there are other ways that are based using collateral information. So in acute care, the nurses might be more aware of how the patient is functioning. In rehabilitation, the nurses might be able to be aware of or ancillary health. And in the community, the family members, if they're there, or caregivers or personal support workers or visiting nurses, might be able to witness third hand, not as reliable, how the patient is functioning. So yeah, it's crucial. Another risk factor for depression is when the patient hits back home. So gets back to their environment and realizes, this is what I cannot do, this is what I used to be able to do, and now I cannot. So that's a risk factor too. So aphasia should not be an obstacle. It's more difficult to assess accurately, and in the worst case scenario, we treat.
Thank you so much, because I think that's a population that gets missed in a lot of this. So sadly, we're almost out of time. Maddie, can you switch to the next slide? You guys have been amazing. We're going to give you in a second, you'll get your last word. I think this conversation could probably have gone on for another 2 hours, given the number of questions that have been posted. So I'm just humbled and grateful and thrilled. Just to let people know kind of where we go from here. Within Heart and Stroke, we've got lots of resources that we've been developing through the best practices and on our website. So if people are looking for resources, if you're looking for support and for the providers out there, we do have 2 online Facebook communities where people with lived experience can go for support. The other place to look for, especially if people are struggling in some parts of Canada, we work closely with the March of Dimes Canada, and they have their after stroke program, and they also have the ability to link people to mental health services. So we encourage you, and they're actually launching a whole mental health program, I believe, next year. So that's another resource to consider as well. And we will, to Abe's point, continue to advocate at all levels, both in government and health services and health systems, to ensure that mental health services are available. And we encourage other people to work with us on that. We are currently updating the guidelines, and we'll be promoting those as well. They'll come out mid next year. So over to you, Stephanie, to do your wrap up.
Sounds good. So just to wrap up, What's one personal message that you would like to share with everyone today, with the audience, just around mental health of women post-stroke? I'll start with you, Becky.
Having a stroke is one of the most traumatic things that someone could go through. So it would make sense that their mental health can and will be affected at some point in the journey. So it should be part of the routine assessment.
Thank you. And Kathy?
Get help. If you are experiencing this right now, and you, like me, feel like getting help or asking for help is difficult and is an admission of weakness, just know that it's better after, right? Things get better once you ask for that help. So just get the help you need.
Thank you both for those inspiring comments. And then just to finally wrap it up, Dr. Abe Snaiderman, what's one message?
Oh my God, after these two ladies have spoken, what else can I add? It's do not lose hope. It gets better. It takes about 5 years to stabilize, find your way. Do not lose hope. Seek help.
Thank you so much to all of you. We are just so appreciative to all of you, and for everybody who's joined in. It's just been amazing how many people have been part of this webinar today. We had, well over 500 people that have joined, and tons of questions and comments. Becky and Katherine and Abe, there's tons of comments just complimenting and thanking each of you. So on behalf of everybody in the audience, thank you, thank you. Next steps for those who didn't catch it all or want to share this, please share this webinar with everybody you know, because it was incredible. We will be posting it on both our YouTube Heart and Stroke channel and on our Stroke Best Practices channel. It'll probably give us a few days to get it all, do what we have to do to it. It will be available, and we encourage you to share it with others who can benefit. We will be sending out an evaluation email to everyone who registered. Please complete the evaluations. Tell us what other topics, tell us what we can do differently. And once you've completed that, you can get your certificate. So for anybody who needs that certificate of participation for your licensing or other professional development, those are available. You have to do the evaluation first, but that helps us as well. So please watch for the emails from Maddie, and huge thanks to Madison in the background who puts all these together for us and keeps us organized. You're awesome. Thank you to my co-host, Stephanie Tesseyman, and huge thank you to Becky, Kathy, and Abe. You guys are amazing. Thank you for all you do to support and champion people with stroke, for women with stroke. And we will be following up with you later. Thanks, everyone. Have a great rest of the week, everybody.